Today we're going to talk about some primary genetic lipoprotein metabolism disorders, and these diseases have some really long names. So please forgive me if I stumble over them because they are tongue twisters, and I will do my best. Once I figure,
Your break included.
I felt like I was never away. Okay, I missed y'all deeply. All right, so the primary genetic lipoprotein metabolism disorders, they're a bunch of like genetic causes of basically dyslipidemias, which is where the lipids get screwed up in the patient. And there's environmental factors that play a role because you might have the genes for one of these conditions, but you live a super healthy lifestyle, so you may never be symptomatic. Or you live a decently healthy lifestyle, but you have one of these mutations and you're going to be very symptomatic because even though you're not making bad choices, your body just doesn't know how to handle lipids. So there's things that make it worse, like poor diet, not exercising, and obesity, but things that can make it better, like good diet and exercising and not having obesity. So there's a lot of genetic factors. You can have like polymorphisms in a variety of different enzymes or defects in like receptors or structural proteins that are involved in the lipoprotein metabolism pathways. And there's also secondary causes like medications, endocrine disorders, like storage diseases like Gaucher's, renal or liver disease, and many others. This little slide kind of summarizes some of the secondary causes of lipoprotein metabolism disorders. You don't need to know all of these drugs. But keep in mind, alcohol is a common cause of elevated lipids because it messes up things, which we talked about a little bit with diabetes. Also obesity, because if you have more fat on your body, you're gonna have more fat in your serum. So we also have like porphyrias, diabetes, hypothyroidism, because your thyroid controls your metabolism. So if your thyroid is not functioning sufficiently, you're going to be slowing down that metabolism, and then the lipids are going to stay in your serum. And also things like nephrotic syndrome, because you're going to be losing a bunch of proteins. So your liver is going to try to make a bunch of proteins, and that includes the lipoproteins. So he's just like in panic mode. He's like, I'm going to make all the things. And that includes things like the lipoproteins. And also things like cholestasis or congenital biliary atresia, because one way that we get rid of cholesterol is through our bile. And if you can't get rid of bile, cholesterol is going to stay in. And that's going to cause problems. So there's other causes that aren't genetic to lipid problems. All right, so I made this figure this morning because that's what I decided to do. So we're going to be focusing a lot on the electrophoresis patterns when you do a lipid protein electrophoresis. And there was a scientist named Fredrickson who came up with a classification system to categorize the different dyslipidemias you can see in patients and for the primary genetic conditions. So a reminder from the lecture that you totally watched over spring break is that chylomicrons will stay at the origin. LDL migrates the slowest because it doesn't have a whole lot of protein on it to pull it to the anode. And then IDL, if it's present, will come between VLDL and LDL. VLDL has more protein on it compared to LDL, so it will migrate a little faster. And then HDL is basically like 50% protein, so he migrates pretty fast. So this is your general synopsis of the lipoprotein pattern, electrophoresis pattern. And this is kind of what it looks like as a electrophoretic, what a normal patient would look like. We shouldn't see chylomicrons in a fasting sample, and we always do this on a fasting sample. So there are different conditions. So the Fredrickson classification, so the type 1 pattern means that there is a high amount of chylomicrons present. And I remember that it's type 1 because chylomicrons are in the 1 position if we imagine we're like numbering these left to right. And the other ones will, depending on the condition, might be low or normal, or maybe VLDL might even be high in some of them. But ultimately, you have high chylomicrons. In a type 2, the one that you have elevated is LDL. In 2A, only LDL is elevated. In 2B, LDL and VLDL elevated. And LDL migrates in the 2 position. All right. In type 3, this is when you have too much intermediate density lipoprotein, and that migrates in the 3 position. So that's our type 3 pattern. And then type 4, are you noticing a pattern? Yeah, okay. Type 4 is high VLDL, and that VLDL comes out in the 4 position. And lastly, 5, you're like, well, shouldn't that be HDL? No, because we don't really care if there's high HDL. We only care if there's low HDL. So 5 is when you take type 1 plus type 4 to make type 5. So you have high chylomicrons and high VLDL, and that's type 5. Right? Okay. So those are the general patterns, and we're going to talk about different diseases and which pattern each of these diseases has. Sometimes they have more than one because they like to be fancy. All right, so as a reminder, exogenous pathway, you have your dietary lipids that you get from your delicious cheeseburger. It gets packaged into a chylomicron that goes through the lymph to the blood vessels, where it then gets some ApoEs and ApoCs from HDL, and then it progresses through the tissues where it runs into lipoprotein lipase on the endothelial cells that interacts with ApoC2, and that sucks the triglycerides out of it. Yes.
The lecture slides is corrupted because all the descriptions is messed up.
Well, that's depressing.
I think it's only in the printed notes. If you go to the other one,
Okay, well, that's not a problem I can fix right now. So go to, Eliza says the printed notes, the non-printed notes works fine. I apologize. I loaded them up this morning. All right, so we need ApoC2 and lipoprotein lipase to get the triglycerides out of the chylomicron. Once he shrinks enough, he returns the ApoC2 back to HDL, and then he can go to the liver, courtesy of the ApoE receptors that on the liver. And then all the lipid cargo that he delivered is now considered endogenous lipids because now they're inside. And they can be then repackaged or stored. So that's the exogenous pathway. So this is mostly mediated by chylomicrons with a little cameo appearance from HDL to donate apolipoproteins. So in our first genetic condition, it's called lipoprotein lipase activity deficiency. And this is an autosomal recessive disorder, and it is pretty rare. And even more rare is when it's not lipoprotein lipase that's mutated, it's actually the ApoC2 apolipoprotein that's mutated. But ultimately, in this condition, we have an exogenous pathway defect. Because we don't have sufficient lipoprotein lipase in the serum, we can't suck the triglycerides out of the chylomicrons. So these chylomicrons never shrink down enough to be taken up by the liver. So we end up with a type 1 pattern where we have high chylomicrons. So we're not getting sufficient shrinkage to get the chylomicrons into the liver. So they just hang out around into the serum for an extended period of time and until it's eventually their turn to get small enough. But it takes a while. And because we're not getting as much of our exogenous lipids to our liver, the liver doesn't have as much to repackage to VLDL and LDL. And so the VLDL is made, but there's not going to be as much of it because we don't have as much lipids in our body. And that VLDL, in order to turn into an LDL, also needs ApoC2 and lipoprotein lipase. So we're not going to do a very good job of converting VLDL to LDL. So that's why we're going to have low LDL. The VLDL can be normal in this condition, but you're definitely going to have a low LDL because you're not going to do a good job of converting VLDL to LDL. So the main clinical results for this is going to be this is such a hard lecture because it's the words. Okay, hyperchylomicronemia. So high chylomicrons, and you're going to have really, 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 really high triglycerides because remember, chylomicrons are extremely triglyceride rich, and now we have a ton of them. So even in a fasting sample, these triglycerides can get up to 10,000 milligrams per deciliter. Remember, like normal is like less, like 150. All right, so this is astronomically high, and their VLDL can be normal or low. LDL and HDL are going to be low, but they have that type 1 pattern. And what you're going to do to diagnose this is you're going to test their lipoprotein lipase activity or test for genetic mutations in ApoC2 or lipoprotein lipase. All right, little cameo appearance from our type 1 again. All right, so the clinical findings of this is going to be diagnosed in childhood because they're going to have a lot of abdominal pain because they're going to get a lot of pancreatitis. The body does not appreciate it when the triglycerides are that high because the serum is really fatty and it's going to glom things up in the pancreas and cause it to get inflamed, and they're going to get pancreatitis. And in addition to having pancreatitis, they're also going to have what's called xanthomas. They're basically little fatty zits that pop up on their skin when the triglycerides get above 2,000. And those triglycerides also start accumulating in the retinas of their eyes. Luckily, it doesn't really cause vision problems, but is a finding that you would see in these patients. But because it's mostly chylomicrons, and chylomicrons aren't as atherogenic as like LDL, they're not going to be overly predisposed to heart disease, which is good. But the pancreatitis isn't going to be fun. All right, reminder of our endogenous pathway. So we have our little nascent VLDL that's made by our liver, and he's got some apolipoproteins on there, but picks up some more from HDL, like the ApoC2, and then he gets to go around the circulation and have his triglycerides sucked out, courtesy of ApoC2 and lipoprotein lipase. And then as he gets smaller, he becomes an intermediate density lipoprotein. And then this intermediate density lipoprotein can donate, either go back to the liver or give a lot of those apolipoproteins back to high density lipoprotein. And when it only has the beta 100, the ApoB100, it is officially an LDL. And the LDL can then go into cells, courtesy of the LDL receptor, or it can go back to the liver. It can also interact with HDL at this point too. So there's multiple fates of these lipoproteins. So what happens when these pathways get messed up? One of these conditions is called familial combined hyperlipidemia. We don't know the cause of this. We think it's a bunch of different genetic factors that combine together to cause this condition, as well as environmental factors like lifestyle. But it is the most common form of hyperlipidemia, but we don't know what causes it. But reason why we care about this is that patients who have this are at much higher risk of developing heart disease compared to patients who don't have it. And it actually accounts for about 15% of people that have premature heart disease. So it's helpful to know if someone has this, because we want to treat them aggressively with lipid-lowering drugs to reduce the risk of cardiovascular disease, like heart attacks and stroke. So one of the notable results for this is that they're going to have an abnormally high amount of ApoB100 compared to how much LDL they have, because they're going to have some decently elevated VLDL. So they're going to have moderately elevated LDL, and I'm saying moderately elevated in terms of the other conditions we're going to talk about today. According to like the National Cholesterol Education Program, this is very high, but according to the other diseases we're going to talk about, this is not that impressive. So we're going to say moderately elevated. And we're going to have high triglycerides, but obviously not as astronomically high as lipoprotein lipase deficiency. HDL can be low. And the Fredrickson pattern they can have can either be 2A, 2B, or 4. And the patient's pattern can change over time. So it doesn't have to stay static, depending on different environmental factors and things. So that means they're going to have high LDL or high VLDL or both. So their lipids are going to be messed up. And we're going to talk about the next two together because they have very similar clinical presentations. So the first is familial hypertriglyceridemia, where we also don't know its genetic defect, but we do know it's autosomal dominant, and that it has a decent prevalence, about 1 in 500, and symptoms occur after puberty. And what happens in this condition is that you just make these really, really big VLDL particles, and they have a whole lot of triglycerides in them. So it takes longer to shrink them down to LDL or to an IDL to be taken up by the liver. So they just hang around longer. So this is going to have a type 4 pattern because we're going to have a lot of VLDL. In type 5 hyperlipoproteinemia, once again, we don't know what causes it, but we do know it's autosomal dominant. And in this case, they are making too much VLDL, but it's normal in size, or they're not doing a good job of removing the VLDL and converting it to IDL or LDL. So familial hypertriglyceridemia is overly large VLDL, and type 5 is just too much VLDL. So this is an endogenous pathway defect because we have too much VLDL going on in here. So in terms of clinical laboratory results, the familial hypertriglyceridemia, they're going to have a moderate increase in triglycerides, not up to the 10,000, but more like the 500-ish range. Normal LDL, they're going to have a normal amount of ApoB100, HDL may be low, and they're going to have that type 4 pattern because it's high VLDL. Whereas with type 5 hyperlipoproteinemia, you're going to have high chylomicrons and high VLDL. So you're gonna have a type 5 pattern. And you can have normal or low LPL activity and normal ApoC2 levels. Both of these conditions are gonna present the same clinically. They're both gonna have the fatty zits, the xanthomas, the lipemia retinalis, the pancreatitis from the high triglycerides, and they will often have abnormal glucose tolerance, because if you're constantly making your pancreas inflamed, he's not going to want to, make insulin very well. So we get abnormal glucose intolerance with this as well. Okay, our next two conditions, we're going to talk about these side by side because they're very similar. This is basically two sides of the same coin where either side can be messed up. So in familial hypercholesterolemia, this is a problem where the LDL receptor in the patient is messed up or mutated, and it cannot bind to ApoB100 on LDL. The LDL itself is fine. There's nothing wrong with the LDL. It just can't, the receptor's messed up. So we don't do a good job of bringing LDL into the cells. So that means the LDL then accumulates in the plasma. And this actually has some varied penetrance. So you can be homozygous for this condition, or you can be heterozygous for this condition. If you're homozygous, your cholesterol is going to be as high as 1,000 milligrams per deciliter. Keep in mind 100's optimal here. So 10 times normal. And if you're heterozygous, it's around the 500-ish range. So not as bad. Luckily, the homozygous is really rare. It affects 1 in 1 million people. But the heterozygous is 1 in 500 people. So someone may have this. Actually, a patient in Dallas had this, and we actually utilized the fact that their LDL is fine, and they would have to go in for plasmapheresis every so often to take off all the LDL. And we would take their plasma, and then we would isolate the LDL in grad school and use it as a little nanoparticle because their LDL itself was fine. So she was fine. And familial defective ApoB100 is where the actual ApoB100 on the LDL is messed up. So the receptor is fine, but the ApoB100 is messed up. So they still can't bind to each other and bring the LDL in. So this is has a prevalence of 1 in 500 in the European populations, and it's very rare in non-Europeans. I feel like this just proves that Europeans have had way too much inbreeding over time. I mean, if you look at the royal line, yeah, way too much inbreeding. But these conditions are basically just the problem with LDL and LDL receptor not being able to bind appropriately. It's just which one is the problem? Varies. So with familial hypercholesterolemia, the severity is going to be based on whether they're heterozygous or homozygous. But the amount of ApoB100 they have is in proportion to how much LDL they have. Unlike with our familial combined hyperlipidemia, where there was too much ApoB100. This is a normal, or it's in proportion to the amount of LDL. They still have high LDL, but the ApoB100 is in proportion to the LDL. They might have normal or elevated triglycerides, so we can get either a type 2A or a type 2B pattern, and their HDL is going to be lower. Whereas with familial defective ApoB100, you're going to have the elevated LDL and the normal HDL and triglycerides. And clinically, these patients will both present, patients with these conditions will have premature cardiovascular disease. The heterozygotes for the familial cholesterolemia will have the xanthomas in their 20s and heart disease in their 40s. Whereas if they're homozygous, they're going to have the xanthomas in early childhood, and they'll have the heart disease in their 20s. This is really bad. So they're going to be treated very aggressively to remove lipids with drugs and plasmapheresis. Well, a familial defective ApoB clinically looks like the heterozygotes for the familial cholesterol hyperlipidemia, and they are at increased risk of cardiovascular disease. All right, our next condition. This is now called dysbeta lipoproteinemia. It used to be called type 3 hyperproteinemia, which I thought was more helpful because it told you that it had a type 3 pattern. But they renamed it. So, but I'm going to use both names because I think it makes sense. So this is a problem with the ApoE on chylomicrons and intermediate density lipoprotein. So this can either be a mutation of ApoE, or the person is homozygous for the ApoE sub2 isoform. And that isoform is just not very good at binding the receptor. And if you're homozygous, you don't have a good one. So basically, because the ApoE can't bind to the ApoE receptor in the liver, these patients do not do a very good job of sending intermediate density lipoprotein back to the liver. So they are converting the VLDL to intermediate density lipoprotein through the endogenous cholesterol pathway, but it just hangs around and until it gets converted to LDL. So it's not taken up by the liver very quickly. So on the electrophoresis, you're going to see what's called a beta VLDL because intermediate density lipoprotein migrates closer to the beta band, which is LDL, compared to VLDL. So it's basically beta to VLDL. So it's called beta VLDL. You'll see both of them on questions, but it's intermediate density lipoprotein. And they're going to have low LDL because they can't really, because they're not doing a great job of getting intermediate density lipoprotein to LDL, and they'll have low HDL as well. But they'll have this type 3 pattern that looks like this. Kind of reminds me of the beta gamma bridge in liver disease. Okay. So this will have a late onset of symptoms, and they have a finding called palmar xanthomas, where the lipids actually accumulate in the lines of their palm. In addition to the little fatty zits, the xanthomas. And they're also prone to premature atherosclerosis because intermediate density lipoprotein is atherogenic. And I realize these hands look like they're children's hands, but this is just a picture I found on the internet of palmar xanthomas. All right, here's a summary table of all the different lipid conditions we just talked about for people who like summary tables. All right. And we will go over these in our case studies on Wednesday. All right, so then we're going to talk about hypoproteinemias, lipoproteinemias. So as a reminder, our reverse cholesterol transport pathway, which is mediated by high density lipoprotein. So our liver makes this little baby nascent discoidal HDL that contains a lot of apolipoproteins, but he doesn't really have any lipid cargo yet. So he's got to go pick up cholesterol from the cells because that's his job. And in order to pick up cholesterol from the cells, he needs to have ApoA1 because the ApoA1 talks to the ABCA1 transporter on the cells, and that transporter gives the cholesterol to the HDL. But at this point, that cholesterol is unesterified, so he can hang out on the phospholipid membrane of this lipoprotein, which means he could decide to jump back to the cell. So we need to trap him inside of the HDL, and we do this by using lecithin cholesterol acyltransferase in the blood, which esterifies the cholesterol, trapping it in the core of the HDL. And at this point, the HDL is now a mature HDL, and it can then use a different transporter to get cholesterol from the cells, the ABCG1 transporter, or passive diffusion. If he is not mature, he will get very rapidly cleared from the circulation. But if he is mature, he can go back to the liver to return the cholesterol he picked up from the cells, or he can go talk to LDL and they can share cholesterol between themselves however they see fit, using cholesterol ester transfer protein. All right, and then LDL can go back to the liver. Going back to the liver is always an option. It's like home base. All right, so we have two conditions where you can have low lipids. And it's low HDL because we don't honestly, if the other ones are low, fantastic. That's great for you. We don't like it when HDL is low because that's the one that prevents heart attacks. So in hypoalpha lipoproteinemia, you can either have a mutation or a deletion in the ApoA1 gene on HDL, or a deficiency of the lecithin cholesterol acyltransferase that you need to trap the cholesterol inside of the HDL. So you have to have both of these functioning in order to turn that little baby discoidal HDL into an adult HDL for it to get the lipids, the cholesterol from the cells. So if either one of those is broken, the HDL doesn't ever mature, and then he gets cleared from the circulation. And then you have low HDL. And because you're not removing cholesterol from various tissues. Patients will end up with cloudy corneas because lipids are accumulating in there. And they'll also have an increased risk of heart disease because all that cholesterol has to go somewhere and it likes to go into your vessels and cause atherosclerosis. And it can also hang out in your kidneys too. So you can get glomerulosclerosis. It's a double whammy. So you get abnormal lipoprotein accumulation in the kidneys, which can cause kidney problems. So this is not great. This one's decently common, all right? Compared to this last one, which is really a zebra, all right? But this is often seen on board questions, even for like doctors, because they want you to recognize that it's a thing in case a patient does have it. You need to be able to recognize the zebra. You can't assume everything's a horse. So this is called Tangier's disease. And this is a rare autosomal dominant mutation of the ABCA1 transporter. And remember, that's the transporter the cells need to get cholesterol into HDL initially for it to become a mature HDL. So if they don't have that functioning, you're never going to mature the HDL. And we've seen like 100 cases of this worldwide. This is like really a zebra. This is very rare. But it is important to know about it. So the most notable results is they're going to have extremely low HDL, extremely low. They're going to have moderately elevated triglycerides and low LDL. But one of the characteristic findings of this is these hyperplastic orange tonsils. So you would see this in a child when they go to the physician and they'd be like, why on earth are your tonsils orange? They might have Tangier's. So that's why they want people to be able to recognize that it's a thing. So that will often be included in the stem of the case study if they have the orange tonsils. We'll also have splenomegaly from lipid accumulation, peripheral neuropathy from lipid accumulation, and foam cells, because if you can't get the lipids out of the tissues, the macrophages come in and start eating the lipids, and then they fill up with cholesterol to become foam cells, and then they start depositing in like vessel walls and cause atherosclerosis. Okay, that was primary lipoprotein genetic disorders. Woohoo! All right, so now we're going to move to cardiac markers. Yay! So we just talked about all the reasons why lipids can give you heart attacks. So now we're going to talk about heart attacks. Yay, heart attacks.
That's not something to celebrate.
Oh, fun story. So I was talking with my brother and he was saying that one of his coworkers had a heart attack at like a women's basketball game. And it was really good he had it there because that meant EMS was like right there. And otherwise he totally would have died because it was like a widowmaker kind of heart attack. But then they had like an AED there to do. So he lived because he had it in a public location where there was already medical personnel. So talk about being lucky. If you're going to have a heart attack, do it surrounded by skilled, trained professionals.
Like a sports event? Like
Yes.
Sports event?
Yes, they had to pause the game for it too, to get him help. But he's fine. He's fine now. Okay, so we're going to talk briefly about heart anatomy. So reminder, we have a right atrium and a left atrium. The right atrium receives deoxygenated blood from the superior and inferior vena cavas that are coming from the body. So the vena cavas actually like run up your torso from various parts of your body, and then they come back to the heart to supply the deoxygenated blood. And that deoxygenated blood goes into the right ventricle, where he gets pumped up to the lungs via the pulmonary artery. And usually we think of arteries as carrying oxygenated blood, but an artery is technically anything that leaves the heart. So if the deoxygenated blood leaves the heart to go to the lungs, it's called the pulmonary artery. And then well, that's a fun noise. All right, so then that blood gets oxygenated in our lungs and it comes back via the pulmonary veins, because anything coming from the body to the heart is a vein. That is a weird noise. And it goes into the left atrium, into the left ventricle, and then he gets pumped out through the aorta to all around the body. So in general, your left ventricle should be very strong. Your right ventricle doesn't need to be as strong because he just has to pump to the lungs. It's not as big of a journey. The left ventricle has to pump throughout the entire body. And so that's how our blood flow works. But most importantly for us is the fact that that blood that's inside the heart isn't actually providing the oxygen and nutrients to the heart. The heart actually has its own blood supply, courtesy of the coronary artery and the coronary vessels that run on the outside of the heart. And this is where heart attacks happen. in these vessels that supply nutrients and oxygen to the heart muscle. So these can get clogged or blocked by atherosclerotic plaques. And if that plaque ruptures, that forms a clot that then blocks the vessel and causes the heart attack. So this is bad. So this is a heart attack is also called an acute myocardial infarction. All right, so in atherosclerosis, we have the little foam cells that are hanging out down here, and they start building up and little causing blockages. And you get this thin fibrous cap, and it's full of all these waste products and cholesterol and foam cells. And it's just a whole hot mess in there. This is a really good YouTube video that explains that hot mess and how it happens. And this can rupture, this little thin fibrous cap can rupture. And then because you now have an open wound, the platelets and red blood cells are going to form a clot right there. And it can block off that artery or that vessel. So we have blood flow. It's not great, but whatever. And then with hypertension or exertion, we can bust open that plaque and then form this clot. And then we have an occlusion, and we're not getting oxygenated blood downstream of this vessel. So the severity of the heart attack is based on where the blockage occurs in this coronary vessel. So the higher up it occurs, the more severe it's going to be, because there's going to be more things downstream that are affected. Whereas if it happened like down here, that's not such a big deal. That's just a teeny tiny part of the heart. Up here, bad. Down here, still bad, but not as bad, right? So where the occlusion happens can have a significant effect on the severity of the heart attack and the person's ability to recover from it. A lot of it's LDL. So LDL is considered atherogenic. So is intermediate density lipoprotein and VLDL. But mostly we consider LDL. Also lipoprotein little a is associated with atherosclerosis. All right, so we have these little vessels, and they're supplying oxygen and nutrients to the cardiac muscle wall. And when it gets occluded, anything close to the outer part of the heart where those vessels are, like the oxygen and nutrients can diffuse. So those aren't going to be overly affected when you're close to the surface. But the things that are deeper in aren't going to be happy. And they're going to start to get oxygen deprived and nutrient deprived. And the longer that lasts, the less likely they are to recover. So as we're getting blacker, that's this tissue dying and getting inflamed and unhappy. So if we continue to have that artery or vessel occluded, we can have permanent damage to that cardiac muscle, which will then affect the heart's ability to pump. So when this tissue gets damaged, it releases markers into our serum, and we call these our cardiac markers. And that's what we, as the laboratory scientists, are going to measure in a patient sample to determine if they've had a heart attack. So our three main cardiac markers for a heart attack: muscle is still a muscle, so it's going to have myoglobin, but this is not very specific for the heart because myoglobin is also found in skeletal muscle. But myoglobin rises very quickly, so it can help us rule in or rule out a heart attack pretty early on, especially if we have changes in their electrocardiogram. CKMB, which is creatine kinase MB, remember this is in the highest concentration in the cardiac tissue. So if this starts to rise, this can tell us that they have cardiac tissue damage. And this generally rises 4 to 6 hours after the heart attack. And then lastly, we have our cardiac troponins. These are the gold standard for heart attacks. They rise within 3 to 12 hours, and these are very cardiac specific. So we have more sensitive testing now for troponins. It used to be that CKMB rose first, but now that our testing is more sensitive for troponins, it now is kind of even on who rises first. So a lot of hospitals have dropped testing CKMB because it's not as specific and it doesn't rise faster now. So we've gotten fancier with our testing. So you do need to know the timelines of when these rise. All right. You also need to know the timelines of when they fall, because it can help you figure out if they've had a second heart attack. Sometimes you get them back to back.
So like when they fall, like
when they return back to normal.
okay,
So this is when they get elevated. So this is the rise of them to when they get elevated. And then over time, they will return back to normal.
it's down in the next.
That is later in the presentation. We will get there. We're talking about rise. Okay, So what does a heart attack look like? We've all seen the dramatic movies where they're like, "Ugh," right? And they're clutching their chest. So that's how it commonly presents in men. Women will often have back pain rather than chest pain because of it's called referred pain. So if a woman comes in with back pain, she should still be worked up for a heart attack because it might be a heart attack. They'll also have nausea, dizziness, shortness of breath, and a common symptom is a sense of impending doom, which honestly, I feel like that's, a valid symptom. Also, ABO transfusion reactions have a sense of impending doom as a symptom. So I feel like that's your body just knowing something is horribly wrong. All right. So when your heart muscle gets damaged, it's going to release these biomarkers into the serum, and we're going to measure them. The doctors are also going to be doing electrocardiograms to look for abnormal heart rhythms. So if you are familiar with an electrocardiogram, there's like the ST and Q waves and things like that. I am not a cardiac expert, but there are two different types of heart attacks. There's an ST elevation myocardial infarction called a STEMI, or a non-ST elevation myocardial infarction, or an NSTEMI. So if they have an ST elevation, then the doctor's like, oh, cool, you're having a heart attack. Let's go fix that. If they're having a non-ST elevation myocardial infarction, then they really do need the lab testing to confirm, because it's not showing up on the electrocardiogram. So we have an important role. All right, so here's a little timeline here. This includes the fall. So our rise, so we have myoglobin rises the fastest and falls the fastest. Then we have CKMB rises second and then falls within 72-ish hours. And then we'll also see AST and LDH will be elevated because those are present in muscle tissues, but they're horribly nonspecific. So we do not use these as cardiac markers, but it would be expected for them to be elevated. All right, it's not telling us something's going on. They don't have hemolytic anemia. All right, it just is something that we expect to see in a heart attack, but we don't use them as cardiac markers because they're not specific enough. And then we have our beautiful troponins. So we have troponin I and troponin T. They rise decently fast within 3 to 12 hours, but they take like up to 2 weeks to go back to normal. So these are not good for figuring out if someone has had a second heart attack. CKMB and myoglobin are good for that because they go back down to normal really quickly. But troponin, no. But if someone had like a little baby heart attack and they go into their doctor and they measure their troponins, they can be like, oh, this is elevated. You might have had a heart attack a week ago. So that's why troponins are still good. Well, they're good in general, but they can be good for delayed diagnosis. Yes.
But I mean, like the plot.
It wasn't bad enough that you sought medical aid.
Or just like far down.
Yeah, it was like far down in the little tree. So it was like a little baby heart attack. Like,
How do you like? It's weird to categorize heart attacks. Do you just
the categorization is based on the severity and how much downstream tissue is affected.
so like if you said a baby heart attack, would you like feel the
I don't know. I've never had a heart attack. I don't know. There's just various amounts here. So if it's like very far down in the coronary vessel tree, you might not have a whole lot of symptoms. You might just think it's like angina or something, or you overexerted yourself. So, or it's heartburn, sometimes heartburn really hurts. So you might not have gone in for diagnosis because it wasn't bad enough, especially when you start getting to old men and they're like, no, I'm fine, and they don't want to go in to see the doctor. So, but then they follow up and they're like, oh, your troponin's elevated. All right. So that's our timeline. All right. So cardiac troponin, this is our gold standard. So the troponins are part of the cardiac muscle complex that helps with contraction of the muscle. And there are 3 parts of this complex. So there's troponin C, which is the calcium binding component, but this is the same troponin C in all of the muscles. So this one's not cardiac specific. Whereas troponin I and troponin T, there is a cardiac version of these that is different than the skeletal muscle version of these. So this is why we use them as cardiac specific markers. So the troponin I is the inhibitory element and troponin T binds to tropomyosin. And they are cardiac specific. So you'll call them cardiac troponin I or cardiac troponin T. And manufacturers can either measure one or both. It's up to them about how they want to do it. So these are the most specific markers that we have for cardiac injury. And cardiac troponin I is considered more specific than cardiac troponin T, because T can be elevated with like renal diseases and other skeletal muscle diseases, but troponin I doesn't have as many of those problems. So it's more specific for actual heart attack than troponin T is. And these increase 3 to 12 hours after AMI onset. And they can be elevated for up to 14 days after the heart attack. But they can also be elevated for other things that cause myocardial injury, like myocarditis or acute ischemia. All right, so we measure these by immunoassays, usually using a monoclonal antibody. Our specimen of choice is plasma, and manufacturers can either measure the free troponin or the troponin complexes. It just depends on the manufacturer, but this has made it difficult to have a consistent reference range between different platforms because they're measuring different things. But the fabulous scientists at the NIST have made a traceable reference material so that we can get more harmonization, because we do have issues where a patient will present to like a rural hospital, get troponin testing done there, and then be transferred to a larger hospital, and they still want to be measuring the troponin values, but they can't compare them because it's apples and oranges. But with this new NIST traceable material, it's more apples to apples, but it might be like a Gala apple and like a Cosmic Crisp, which is by far the best apple, by the way. I think so. I lived in New York for 4 years. I have very strong opinions on apples now. That's what happens when you live in New York. Okay. And so our turnaround time, depending on the manufacturer, is 5 to 30 minutes. And these are always run as stat tests because you want to tell if someone is having a heart attack. That is considered an emergency, right? So it's always stat. Turnaround time is usually less than 60 minutes. And we now have this high sensitivity cardiac troponin testing, which allows us to go to like nanogram per milliliter levels of sensitivity. So our reference interval for this is less than 10 nanograms per milliliter. And some doctors, because they like to have all the data, which I don't blame them for, they actually like to do serial sampling of the cardiac troponin levels. So even though they've already diagnosed the patient with a heart attack, they want to see how severe the heart attack is to kind of see how high the troponins get up. So they'll just keep measuring the troponins over time until they see it start to fall, because that kind of tells them, oh, this is how severe this is. But they don't have to keep doing that. They just like to. They've already diagnosed them. All right, so myoglobin, we've talked about him before. He's got oxygen binding protein. He's found in muscle. The myoglobin in skeletal muscle and the myoglobin in cardiac muscle are the exact same myoglobin. So this is not specific for the heart. It could be elevated for any sort of skeletal muscle injury. But the amount of myoglobin found in the serum does rise in relation to how much damage there is to the tissue that's being damaged. So it's sensitive because it rises very quickly, but it's not very specific to the heart. It can also be elevated with things like kidney disease, or if there's like muscle damage. So if someone comes in with a car crash and they're like, okay, is their myoglobin elevated because they were in a car crash, or is their myoglobin elevated because they had a heart attack while they're driving and that's why they had a car crash? This would not be a good thing to do. We wouldn't be able to tell they were having a heart attack if we know their skeletal muscle injury. But it does rise very quickly. So if someone's coming in with symptoms of a heart attack, and this is normal, it can help us rule out heart attack pretty early on. Whereas if it's elevated, we're like, oh, okay, well, that might be a heart attack. And then we know to keep following up with them, and we'll start measuring troponin and see if that starts elevating as well. So you can assay this over time to look for rising values, and this will fall to normal within 36 hours. So it goes back to normal really quickly, which is really good because if someone's in the hospital because they just had a heart attack, and then they start having chest pain again, you can then measure the myoglobin and see if it's rising again. So you can see, did they just have a second heart attack? So, because that does happen. And we'll measure this with an immunoassay, and we can't use a hemolyzed specimen, and we can do this on like point of care instruments or automated instruments. And there is a difference reference range for males versus females because males typically have more skeletal muscle than females do. All right, so our next cardiac muscle biomarker is creatine kinase MB. So this is found, it's got 3 isoforms. So the MM, which is found predominantly in the skeletal muscle, MB, which is found predominantly in the cardiac muscle, and BB, which is found in the brains and the intestines. But we really don't see a whole lot of the BB form in the serum. So we can pretty much just kind of ignore he exists in terms of our testing. And we measure CKMB to see if someone's had a heart attack. So this is less sensitive than our troponin assays, especially with our high sensitivity troponin tests that we have now. And because we have our high sensitivity troponins, this doesn't rise as quickly compared to the troponins anymore. So this used to be much more popular, but he's kind of fallen out of favor. Troponins are more awesome. They're more sensitive. They're more specific now. A lot of hospitals don't even measure this anymore. But they go back to normal pretty quickly, which is good. So it can be used to measure reinfarction if someone's had a second heart attack, because it doesn't take 2 weeks to go back to normal. It goes back to normal within 72 hours. So that's why we still like it, but we don't necessarily like it so much for the initial diagnosis anymore. All right. So we can also measure the total creatine kinase in the patient's serum as well as the CKMB and use that to figure out if the CKMB is elevated because of a skeletal muscle issue or a cardiac muscle issue. Because skeletal muscle is about 4% CKMB and cardiac muscle is about 20% CKMB. So if we do a ratio or a percentage of how much of our total creatine kinase is CKMB, if it's greater than 6%, that tells us it came from the heart because the heart has more CKMB. Where if it's just a skeletal muscle, that should be below 6% because only 4% of the skeletal muscle is a CKMB. So we can use that to figure out if the total CK elevation is cardiac or skeletal in cause. All right, and then, okay, so this is something that you do need to understand. All right, so we are going to measure CKMB activity using an immunoinhibition assay. And I swear I try to explain this every year, and every year I ask a question on the test, hint, hint, and people get it wrong. So we're going to really try to get this time, okay? I believe in us. So we're doing an enzymatic assay, and we're going to look for the activity of CKMB, but we don't want to measure the CKMM that's also in the serum. But we don't have necessarily a good way to separate those. We don't have to do a separation step. That's annoying. So what we're going to do is we are going to incubate our serum with an antibody that only binds to the M subunit of creatine kinase. And that antibody is going to block the active site of the CKM subunit. So each of these subunits has catalytic activity. All right. And if I have CKMM, this antibody is going to block both active sites. So he is dead to me now. He has no activity. But CKMB, only the M subunit's blocked. This B subunit still has an active site that's open, right? He's still available. So this B subunit is going to react in my creatine kinase assay, which we learned about in our enzyme unit. And then because we only had half the activity of this little CKMB, because only half of this guy was functional because the other half was blocked, at the end of this, we're going to multiply by 2 to take into account the activity this would have contributed if we hadn't blocked him with an antibody. So that gets us our CKMB activity. Does that make sense? This is immunoinhibition. So I have added a antibody to block the M. So only B is going. And because there's not a whole lot of CKBB in the serum, we pretty much just don't care about him. He's technically active, but he's not really present. So, okay, good. All right. All right, our time course again. I feel like I've talked about the time course enough and to know that you should know this, right? All right, so myoglobin, 1 to 2 hours, falls within 36. CKMB rises 4 to 6 hours, goes back to normal within 72. Troponins rise in 3 to 12, falls within 2 weeks. And then we have AST coming in, LDH coming in. We don't really care about their rise and fall. I just want you to know that they play a role here. They're in there, but they're not specific. And the cardiac markers that fall quickly, i.e. myoglobin and CKMB, can be used to see if the patient has a reinfarction. Because the cardiac troponins will still be elevated after the first heart attack. All right, so how do we make sure we don't send someone home from the emergency department that's having a heart attack? Because that is a legal nightmare. And, it's bad for the patient. So someone presents to the ED because they're experiencing chest pain. And we don't know how long they've been experiencing the chest pain. We just know that they're the ED now. So the onset of when they've started getting these physical symptoms and when they show up to the ED might be several hours apart. But we're going to base our sampling times based on when they showed up to the ED. All right. So the recommended measurements at admission to the ED is you have to measure myoglobin because we want to quickly rule out heart attack or no heart attack. If that's still looking, it's like maybe it's a little elevated or it's looking normal or we're still not sure. At 3 hours, we're going to measure troponins. We might measure CKMB, depends on hospital policy. And then if that's still looking normal, we're like, okay, well, let's just make sure. We'll wait another 3 hours. We'll measure the troponins again. So now we're 6 hours. And by this point, we have a reasonable assumption that most things should be elevated. But it could take the troponins up to 12 hours. So we still don't necessarily want to send them back yet, send them home yet. So we're going to wait a full 12 hours before we definitively say, you do not have a heart attack. If at any point any of these are abnormal and we can confirm a heart attack, we can stop testing. But we do not send someone home if we think they might be having a heart attack until at least 12 hours. Because everything should have risen by 12 hours. All right. So you're going to be looking for rising values or just straight up abnormal above the reference interval values.
They take longer to diagnose. Does that mean they're more at risk at dying?
No, because think about it. If it's a really bad heart attack, it's going to rise really quickly, right? Or if it's tiny heart attack, especially one that doesn't have a ST elevation, because that's usually why smaller heart attacks don't have ST elevations because the heart's not as affected. We don't want to send them home if they've had a little heart attack, but it's going to be decently easy for us to figure out if they've had a big one because these values are going to rise faster and they're going to have electrocardiogram issues. But we don't want to send the people who have tiny heart attacks home because we want to fix the problem, right? Because you can go in and do like catheterization and things like that. Yes, Eli.
I was gonna ask how hard that should be treated.
Catheterization, so they'll go in and send a little wire down and then they'll open up like a little balloon to open up the vessel again. So they'll put in a little stent to open it up. Some doctors get paid a lot of money to do that with lots of training. All right. So acute coronary syndrome is the umbrella term that we use to label people that have unstable ischemic heart disease. So this could be as severe as a heart attack or as mild as angina, where you climbed up the stairs and your chest felt a little twingy, So this is angina is unstable ischemia without any sort of actual muscle damage. You just have occluded vessels and they're not super great at pumping blood. So if you tax them, you feel it a little bit. But the major cause of these is atherosclerosis. So if someone has a heart attack, they will go in and open this up. But people, you can also, if you are at high risk of heart disease, they can actually like image your heart and figure out which vessels are blocked and then preventatively open them up to help prevent heart attacks, which is good. So we want to treat people that have acute coronary syndrome aggressively so that they don't have a heart attack or a stroke, because a stroke is basically a heart attack in your brain. So they'll do this by putting them on nitrates. So sodium nitrate, if you can take it as like a little pill when you get chest pain, that basically causes your blood vessels to dilate, which will increase your blood flow. And you can also do beta blockers to lower blood pressure, antithrombotics, so you don't clot if one of these was to occlude, anticoagulants, and coronary catheterization, like this. So things that affect your risk for developing acute coronary syndrome: smoking, high blood pressure, high cholesterol, diabetes, physical inactivity, being overweight or obese, or you have a family history of chest pain, heart disease, or stroke. So I have a family history of these. So I should probably be better at things. Then the symptoms of this is like chest pain or discomfort, especially with exertion, pain or discomfort in one or both arms, jaw, neck, back, or stomach. So also with heart attacks, if you're having a heart attack, the pain can radiate down your arm and your arm can start feeling numb and tingly. Shortness of breath, dizziness, nausea, sweating, the sense of impending doom, things like that. I mean, it's a real symptom, okay? Cardiac marker testing, if you're think someone's actually having a heart attack, there is some debate right now about whether troponin levels can be used to assess risk for acute coronary syndrome. If someone has a higher baseline troponin value, that could indicate that they have higher risk for coronary syndrome, but that's still under research right now. So, and looking for like EKG abnormalities. All right, so angina is where you get chest pain because the heart temporarily doesn't have enough oxygen-rich blood supply. So because the coronary vessels are narrowed or blocked a little bit, so you just get a little transient ischemia. It's just not quite enough oxygen, but it doesn't cause damage to the tissue. It's just temporarily unhappy. It's like when you hold your breath underwater. Like you're not going to be hurt from it, but it's not super comfortable. And so this can be a symptom of an underlying problem. And a lot of times if someone has an angina episode, that is kind of a precursor to them having a heart attack. It's kind of like your little warning sign that something's going on. So angina symptoms can present like up to a month or even like 24 hours in advance of a heart attack in some patients. And someone who has unstable angina might have some elevated cardiac troponins. They don't have any clinical signs of a heart attack. Like they don't have chest pain. They don't have any EKG abnormalities. All right, so we also have high sensitivity C-reactive protein. So we've talked about C-reactive protein before. It's an inflammatory marker that's elevated in acute inflammation, but we've also now developed tests that are more sensitive than our standard CRP assay. And this helps us detect low levels of inflammation, which is associated with atherosclerosis. So this is more precise and sensitive than our standard CRP assays, which is why it's called high sensitivity CRP. And we can measure this in patients that are at higher risk of acute coronary syndrome to kind of provide further knowledge as to their risk for developing atherosclerosis and heart attacks. So, because their CRP levels should be elevated if they have atherosclerosis because it's an inflammatory condition. But it doesn't tell you they're having a heart attack. This is not a heart attack marker. This is what is your potential risk in the future of a heart attack or stroke? So this is a preventative test, not a diagnose in the ED test. All right, so we're going to measure this by immunoassay in serum or plasma and using a very, very sensitive immunoassay. So we're going to do immunoturbidimetry or immunonephrolometry. And if you have a value less than 1, that means milligram per liter, that means you're at low risk of acute coronary syndrome. If you're between 1 and 3, you're at moderate risk. And if you're greater than 3, but under 10, you're at high risk. Because if you're over 10, that means you have acute inflammation. And the patient will have to come back later when the acute inflammatory condition is gone to get this remeasured. So this is only useful if they don't have an acute inflammation. So we want to see what their baseline level of inflammation is with this high sensitivity CRP to see if they're at increased risk of acute coronary syndrome. All right, so homocysteine, this is an amino acid, and this used to be used a lot as a cardiac marker, and it's still used overseas quite a bit, especially in like the Middle East. But homocysteine is an amino acid formed from the demethylation of methionine in the plasma. And what we have noticed through epidemiological studies is that people that have higher levels of homocysteine in their serum are at higher risk of developing premature cardiovascular disease because it's associated with having more atherosclerotic plaques. So there's a condition called homocystinuria, which is a metabolic disease where they obviously have high levels of homocysteine. So they're at higher risk of cardiovascular disease. And so this can be measured to monitor for acute coronary syndrome, but this isn't really done so much in the United States, more overseas. But it is something to be aware of as a thing. But they think that if you give a patient a folic acid, it helps prevent some of the homocysteine buildup. So that's cool, which can then reduce the cardiovascular disease progression. All right, so then we have lipoprotein little a, which we talked about during our lipids, where it is basically a low density lipoprotein, but the ApoB100 has gotten a little wonky, and a little apo little a has attached to the ApoB using a disulfide bond. And this lipoprotein A looks very similar to plasminogen, which is part of the coagulation cascade. And it's considered thrombogenic. So having high levels of this lipoprotein A, even if your LDL is normal, puts you at higher risk of cardiovascular disease and stroke. So this can be measured in patients, especially if they have a family history of early onset cardiovascular disease. And we will measure it using an immunoturbidimetric method, where we have latex particles that are coated with an antibody against that lipoprotein little a. And that will cause immune complex formation, which will then increase light scattering. And then we can measure the amount of light scattering using turbidimetry. I like this picture. Okay. Now it does kind of look like an eyeball, right? A weird eyeball. An eyeball that's seeing like rainbow colors. Anyway. All right, so our last condition is congestive heart failure. So congestive heart failure is very common in elderly people because this is something that kind of progresses over time. So the longer you've been alive, the longer you've had for this to progress. And what happens in congestive heart failure is there's a ton of different causes of it. And this YouTube video is like a 14-minute YouTube video that goes into all the different causes and what happens. And it was quite entertaining to watch today. But the net result of congestive heart failure is that the heart can no longer pump effectively. It cannot contract strong enough to pump blood to the body. So because it's not contracting strong enough, that blood is just kind of chilling out and hanging around places where it's not supposed to. So this slows down the blood flow. And this slowing down or stasis of the blood flow allows the fluids to move into tissues where they are not supposed to be, like your lungs, which is why it's called congestive, because it starts to congest your lungs. So your alveoli will fill up with fluid, which then makes it harder to breathe because all the little oxygen and carbon dioxide have to diffuse through liquid as opposed to just crossing into wherever they're supposed to be. So they get shortness of breath, and the heart gets all stretched out. And when the heart gets stretched out, that causes us to release the natriuretic peptides. So our cardiac marker for monitoring and diagnosing congestive heart failure is actually measuring the brain natriuretic peptide, because as the heart gets distended from this congestive heart failure, we get more natriuretic peptides. All right, so there is a variety of causes of this. All right, it can be right-sided, it can be left-sided, it can be diastolic, it can be systolic. There's a whole host of causes. Previous heart attack can cause this. All right, so there's a lot of different causes of congestive heart failure. But ultimately, the heart becomes too weak or too stiff to pump. It is no longer a nice, strong heart. All right. So I like this one. You can see like it's got this little thin wall that happens in some forms of it. But they're going to have the shortness of breath because their lungs are filled with fluid. They're going to have fatigue because it's really hard to get oxygen. They're going to have edema, especially in their legs, because all that fluid is going to go where gravity is, which is, your feet. And this doesn't usually present with chest pain, which is nice. But they will just still also get like acidic fluid, and it will be a transudate acidic fluid because there's nothing wrong with it. It's just, they're just fluid loaded from not being able to pump things appropriately. So with this, they're going to have increased brain natriuretic peptide. They're going to have a lot of electrolyte imbalances because of fluid retention, and the kidneys aren't going to be happy with the slow blood flow. And so we're also going to see high BUN in here because remember, if the blood flow is slow in the kidneys, that gives us more time to absorb BUN. So but congestive heart failure can also cause kidney problems. So they might also have high creatinine, but they're definitely going to have high BUN. All right. They'll have elevated CRP, proteinuria, hypertension. Hypertension is one of the main causes of congestive heart failure. And they'll have abnormal EKG measurements because the little floppy heart doesn't do a good job of pumping. I took a pathology class, and the pathologist brought in a heart with congestive heart failure. They're like really big and like they're floppy. Like the heart should not be floppy. He brought in like a normal heart and like a congestive heart failure heart. Not a good comparison. All right. All right. So B natriuretic peptide. So this is released by the cardiac ventricles when there is increased blood pressure and the ventricle gets stretched out. And this basically turns off the renin-angiotensin-aldosterone system, which is good because we don't want more fluid. We already have too much fluid. So this will help us get rid of fluid, this B natriuretic peptide, and salt, because the kidneys will start to excrete more sodium, and then water will follow, which will help diurese some of the fluid off of the patient. And well, this can also start causing some weird sodium values and electrolyte imbalances. But ultimately, our goal is to get rid of fluid in this patient. And that's what that natriuretic peptide is trying to do. It's trying to lower their blood pressure and get rid of fluid. And the amount of B natriuretic peptide we see in the serum correlates to how severe the ventricle is swelling or how bad their congestive heart failure is. Atrial natriuretic peptide is also released in congestive heart failure, but it has a really short half-life in the serum. So it's just not easy to measure. It just doesn't hang around very long. So it's easier to measure B natriuretic peptide. All right, so we use B natriuretic peptide for diagnosis and monitoring of congestive heart failure. And this range is kind of the unisex range. There is usually a male versus female, but this is the unisex range. So normal is less than 200 picograms per milliliter. That either means they don't have congestive heart failure or they're compensating enough for it not to be symptomatic right now. If it's between 200 and 400, they have moderate congestive heart failure. Greater than 400, they have moderate to severe congestive heart failure. And we can also measure the N-terminus of the pro-BNP as opposed to measuring BNP, but they're in a 1-to-1 ratio. So there's not a difference in the reference range. It just depends on what the manufacturer wants to measure. We'll measure this in EDTA plasma. And we have to use a very, very sensitive electrochemiluminescent assay because this is like picograms per milliliter. This is so low. These are super tiny levels. So we have to use a very sensitive assay. And last slide. Now we have inflammation of the heart. So the heart is made up of several different layers. So we have the endocardium, which lines the inside of the heart where all the blood is filling up. We have the myocardium, which is the actual muscle of the heart. And then we have a pericardium, which is technically 2 layers with a bunch of fluid in the middle. So that way, when the heart squeezes, it doesn't like rub against the cavity of the chest. So there's lubrication when it squeezes, and you can get inflammation of any of those layers. So if it's inflammation of the endocardium, it's called endocarditis. This can be due to like an infection, or myocarditis, which is inflammation of the myocardium. Pericarditis, which is inflammation of this outer layers. And this can be acute or chronic. And there's a variety of different causes like infection, autoimmune conditions, drugs, cancers, trauma, whatever. So since this is an inflammatory condition, you'll have high CRP, and you will often also have elevations in cardiac markers as well, because there is possibly some damage, but it's not going to be like to the level of a heart attack. All right. And then we have our key topics. So know the rise and falls of our heart attack markers, be able to discuss how atherosclerosis happens and how we get heart attacks. The various sensitivities and specificities of our cardiac markers, how are we going to rule out an AMI in the ED, and how we use CRP, homocysteine, and lipoprotein A for assessing cardiovascular risk, and also BNT for congestive heart failure. And we did it. And that is the end of Unit 3. That is all the content. We did it. Yay! That means you only have 1 unit left, guys. All right. So Wednesday, we have a case study Friday, we have a review, especially since we had the great void of spring break in there. And Monday, you have an exam. And this week, you have a quiz. Okay, so I believe in you. After this unit, we get very concept based, and I'm very excited about that. Endocrinology is all like, this goes high and the pituitary tries to fix it, or this is broken and this other guy tries to fix it. It's just a bunch of anthropomorphizing different glands and figuring out which one's on the struggle bus. So that's essentially what goes on. And we will have a fun activity on the first day of endocrinology where you get to throw balls at each other. So